We have some amazing speakers here today. I will be giving our introductory talk, and the focus of today's talk is on introducing critical care EEG, but also some of the challenges in making critical care EEG more widely available and some of the ways that we can address those challenges. With us today, we also have Dr. Aaron Struck from the University of Wisconsin. He is an assistant professor. He has an interest in data science, neuroimaging, and EEG, and he's going to be talking us a little bit about the ictal-interictal continuum and risk stratification for patients who are undergoing critical care EEG. We also have Dr. Zubaydah Sheikh. She is from the Virginia Commonwealth University, where she is an associate professor and fellowship director, and she is going to be talking to us about rapid access setups and ways that we can improve accessibility of EEG through those devices. With that, I will go ahead and get started. So I will mention, for my disclosures, I do have fiduciary responsibilities for the American Board of Clinical Neurophysiology and the ABRET LTM board, neither of which I think are relevant to this discussion. Most of you, hopefully, within this room are aware of many of the indications for which we use ICU EEG monitoring. And there are 5 indications that have been proposed as part of a consensus statement that's now a decade old as part of the indications for continuous EEG in critically ill adults and children. The most common reason, overwhelmingly, why we perform ICU EEG is for the diagnosis of non-convulsive seizures and status epilepticus. It's also helpful in diagnosing other events and determining whether or not those events may be seizures. We use it also in the assessment of the efficacy of therapy for a patient who may actually have seizures or who has status epilepticus. It's important to know whether or not our therapies are working, and EEG can be the only tool that can really give us a sense of whether or not things are working. We use EEG to help us determine if there is cerebral ischemia in some subject patient populations. For example, patients with subarachnoid hemorrhage from ruptured cerebral aneurysms. We can use EEG to help us identify when patients are at risk for delayed cerebral ischemia due to vasospasm. We also use EEG for monitoring sedation, especially for patients who are on IV anesthetic medications like pentobarbital, midazolam, and propofol. And last but not least, we can also use ICU EEG to assess the severity of encephalopathy and use it to prognosticate the outcome for our patients. When we look at all comers across multiple different studies, if we look at all ICUs, medical intensive care units, surgical intensive care units, trauma intensive care units, and neurologic intensive care units, the incidence of seizures is fairly high at 21%, with an incidence of non-convulsive status epilepticus at approximately 13%. If we just restrict our examination to medical and surgical intensive care units, as you might anticipate, that number drops to about 13% and 6% respectively. And if we restrict our assessment to neurologic intensive care units, that number increases with an incidence of seizures of about 24% and an incidence of non-convulsive status epilepticus of approximately 12%. Children, pediatric, and neonatal intensive care units have a higher incidence of status epilepticus and seizures overall. If you look across multiple different studies, the overall incidence of seizures in the pediatric patient population is approximately 35%, with the overall incidence of non-convulsive status epilepticus of 19%. The underlying diagnosis makes a big difference in terms of what your likelihood of developing seizures and status epilepticus may be. If you have no underlying neurologic illness, you are less likely to have seizures, as you might anticipate. Some of the highest incidence of non-convulsive status epilepticus and seizures are seen with those who have traumatic brain injury, particularly those who have traumatic brain injuries associated with blood products. We also see a high incidence of seizures and status epilepticus in those who have encephalitis, whether that is from autoimmune etiologies or infectious etiologies. And anybody who has blood products, whether that is intraparenchymal or subarachnoid hemorrhage, is very much at risk for the development of seizures and status epilepticus. When we look at the way that non-convulsive status epilepticus presents in the intensive care unit, the most common way that we see patients present is with altered mental status. Most patients just have coma, they just have altered mental status, they have no physical manifestations of their seizures whatsoever. There are no reliable clinical signs or symptoms that we can point to that are more likely to be associated with their seizures. We can occasionally see other signs and symptoms, but again, altered mental status is the most common sign that we see for patients with non-convulsive status epilepticus in the intensive care unit. And it is worth noting that it does make a difference whether or not your patients are having seizures and status epilepticus. So in a study that was focused on pediatric patients, they looked to see what happens if more than 20% of your time is spent actively seizing. And what they were able to show is that the seizure burden, the presence of a greater than 20% seizure burden, is associated with neurologic decline. So those individuals who had seizures for more than 20% of the time overall had a worse neurologic outcome than those who did not. So I want to focus a lot of the remainder of this discussion on some of the issues that are barriers to EEG in the intensive care unit. And when it comes down to it, there are a lot of different issues that can be barriers to EEG in the United States as well as abroad. One can be something as simple as ICU availability. Not every place has a neurologic intensive care unit. Those places that do, there may be limitations in machine availability. I am in a large academic center. We have 26 ICU EEG machines, and we still run out of machines occasionally. I would say one of the bigger issues is the availability of EEG technologists. We are facing an 11,000 EEG technologist shortage here in 2025, and this is something we were just talking about prior to the beginning of this talk. It is something that many institutions, both academic and non-academic, are facing, and it is one of the more pressing issues that faces the area of ICU EEG. But in addition, do not sell yourself short. The issue of physician availability is also a problem. More and more physicians are being asked to read EEGs 24/7 and then come into work the next day and see a full round of patients, and it's becoming increasingly challenging. So we'll talk a little bit about that as well. I put this slide in here to remind you that although we think about ICU beds as being readily available across the country, there are still many areas of the world, many areas of the country in which ICU beds are not readily available. And there are some areas, some counties in the United States in which there are no hospitals at all. 10% of the US population lives more than 30 minutes away from a hospital. And when we're planning critical care services and ICU EEGs, it's important to take into consideration the fact that there are many areas of the United States that do not have ready access to critical care services. One thing that has been highly noteworthy is that when we look at where critical care EEG is taking place, it tends to be in areas with lots of ICUs. And that tends to be in the northeastern United States, where we have a lot of population concentration. It tends to be in facilities that have a lot of hospital beds. And overwhelmingly, it tends to be in urban teaching facilities, with some being seen in urban non-teaching facilities, but increasingly we're seeing a growing disparity in the use of critical care EEG in rural versus urban locations. And I say this because I come from South Carolina, which is a state that has a very large non-urban population. When we look at the per capita ICU capabilities of different areas, we see that although the Northeast does have a high concentration of bed availability, the per capita availability of beds in those areas is not necessarily as high as you might think. And even some of those areas where it seems like there are a lot of beds available, When you look at the per capita availability, it is less than you might otherwise imagine. When we talk about neurologic intensive care units, the Neurocritical Care Society has divided neurocritical care units into 3 basic levels of services that they are able to provide. Level 1 services are what we all aspire to. That's when you're able to take care of complex neurologic emergencies requiring advanced interventions and comprehensive care. These facilities provide the gamut of neurosurgical and neurointensive interventions. Level 2 neurologic ICUs are there to stabilize acutely ill patients. They should also be able to safely manage stable neurocritical care processes. And it is worth noting that the majority of neuro ICUs are at level 2 and not at level 1. Level 3 is what we see in most medical intensive care units where a neuro ICU is not available. That's when they are able to provide emergent evaluation and stabilization and facilitate transfer when appropriate. These often do not have an in-house neurologist available 24/7, and they rarely have a neurocritical care specialist available. When we look at the recommendations made by the Neurocritical Care Society, they recommend that even at a level 2, continuous EEG services should be available, including the availability of 24/7 stat EEG services and constantly available EEG machines. And I bring this up because, as you'll see in a minute, there are a lot of facilities across the nation that fall short of this. If you look at the statistics about status epilepticus and hospital transfers, between 2007 and 2018, there were 7.4 million emergency room visits for seizures and 420,000 emergency room visits for status epilepticus. Compared to many other diagnoses, the diagnosis of status epilepticus is associated with a very high incidence of requiring transfer for another facility. About 20% of the people who come into the emergency room are going to have to be transferred to another facility directly from the emergency room. 5% will need transfer later once they've already been hospitalized. And if you compare this with all other diagnoses, the rate for other diagnoses is usually about 1.5%. So we are something that requires a lot more transfer services than other diagnoses. What we've also seen is an increase in the rate of the diagnosis of status epilepticus. So if we compare the diagnosis overall since 2007, the incidence on average of diagnosis has been increasing by about 5.9% per year. Some of that is probably due to the fact that we're now recognizing more cases of status epilepticus that were previously non-convulsive and had no physical manifestations because of the more widespread use of EEG. As a consequence of this more widespread use of continuous EEG and more widespread diagnosis of status epilepticus, we're now also seeing a higher transfer rate of patients related to the diagnosis of status epilepticus. As you might anticipate from what we've been saying before, you are much more likely to be transferred if you are from a rural facility, if you have a high degree of medical comorbidities and are therefore medically more complex, if you are on a ventilator, and unsurprisingly, if you are at a facility that does not have continuous EEG capabilities, you are much more likely to be transferred. Transfers cost both money and resources. So the cost of an ambulance transfer is at least $800, and if you look, practically speaking, the majority of the time, the cost that patients incur is much closer to $2,500. The median cost of a helicopter transfer is $4,100, so even more expensive. Having said that, that's really just the tip of the iceberg when it comes to the cost of hospital transfers, because people who get transferred in general end up using a lot more resources. So if you look at all comers, for the individuals who are transferred to a different hospital, they end up using somewhere between $9,600 and $18,000 more resources than individuals who are not transferred. And now this may be because those individuals in general are more medically complex, they have more comorbidities, but we should also think about the way that this is impacting not just the patients and their medical costs, but also their families. So this is particularly an issue for those of us who care for patients who are in rural communities. The cost to families can be prohibitive. There is the cost of traveling back and forth, the cost of lodging so that they can be close to their loved one, and then there is the inevitable cost of lost wages, because if you have to travel 2 to 3 hours to be close to your loved one, there is no way that you are getting to work. And these unmeasured costs are something that we often fail to take into consideration when we're caring for our patients. It is also worth noting that many of these patients who are getting transferred may not necessarily need to be transferred. So if you look at the ones who are being transferred from the emergency room, close to 20% of those transfers will be discharged within 24 hours of their transfer, suggesting they may not have needed to be transferred after all. More than half who are transferred will be directly discharged to home, indicating that maybe they just needed a little bit of time to wake up and they're usually back to baseline relatively soon. And what I also thought was pretty interesting, 70% of those individuals who are transferred will receive EEG at the hospital to which they are transferred, but that means 30% are not getting EEG at the facilities at which they're transferred. And you really have to ask yourself, why are they getting transferred for their diagnosis of status epilepticus if they don't need an EEG? There is a problem with EEG access almost universally in many parts of our country. Only 27% of hospitals are EEG capable, and that includes both routine and continuous EEG. Urban hospitals, as I mentioned, have a better likelihood of being EEG capable, and they have shown a growth in the incidence of EEG capability. So in 2012, 31% of urban hospitals were EEG capable. Now that number is 41%. But distressingly, the number of rural hospitals that are EEG capable has declined from 4% to 3.2%. This may be because our urban and our rural hospitals are competing for the same resources. They're competing for physicians, they're competing for technologists, they're competing for the money necessary to have machines and equipment available. It is also notable that for hospitals that do offer EEG services, the percentage that offer continuous EEG services has increased significantly. It has increased from 9% to about 23% currently. There are estimates that suggest that continuous EEG monitoring is something that we're more likely to use in our younger patients, and I don't have a great explanation for that. We are also more likely to use continuous EEG services in our Medicaid and private insurance patients, and in our patients who we know have multiple comorbidities. And as mentioned previously, one of the best predictors for whether or not you will get continuous EEG monitoring is where your hospital is located, with urban, northeastern, and teaching hospitals using the majority of the resources. In a very recent survey, and by very recent I mean published last month, a survey of ICU EEGs in academic centers, they assessed the trends that we're seeing currently in these academic centers. 94% of the individuals who responded to this survey were university or university-affiliated centers, and the overwhelming majority had EEG labs for over 30 years. What's interesting, however, is the trends that you can see in the number of patients that are being monitored and the number of technologists that you see. So what's notable for me is that the overwhelming majority of these facilities now have more than 20 patients in their neurologic intensive care unit, which is a lot of patients. And there's an interesting sort of dichotomous spread in the number of available EEG technologists, with the average being somewhere, or the median being somewhere between 6 and 10 EEG technologists, which barely scrapes by the number to get you continuous EEG services as well as outpatient EEG services. What's also noteworthy is that the majority of inpatient academic centers are now using quantitative EEG. The overwhelming majority are using remote access, and I don't know how you would do it without remote access these days. And interestingly enough, many are also using the newer ACNS terminology, which was originally published in 2013 and was updated in 2021. I think it's also fascinating looking at these academic centers and the number of faculty EEG readers that they have. Again, the median is somewhere in the realm of 6 to 10, but there are many institutions now that have over 15 faculty readers. I would love to be at one of those facilities. There's also a lot of fellows who provide assistance in reading and interpreting EEGs, but the median still remains 1 to 2 fellows at any given center. The majority of places read and update continuous EEG reports to the ICU team on average twice per day. And that's important because that's essentially our recommendation for all of the different indications for which we do ICU monitoring. The minimum at which we should be updating our ICU team is at least twice a day, whether that's for diagnosing seizures or status, assessing efficacy of treatment, monitoring sedation or burst suppression, assessing encephalopathy, and if you're monitoring for cerebral ischemia, the current recommendation is to monitor and report at least 3 times daily. Having said that, twice daily is the baseline at which we should do this. And if you have somebody who is actively seizing, as most of you I hope realize, you may be monitoring and reporting on what's going on with somebody every hour, or even more frequently than that, because those patients are highly unstable and you may need to update the team very frequently. So ICU EEG generates a lot of data. Depending on how quickly you read and depending on how many pages you do in a second, a 24-hour EEG generates between 5,800 and 8,600 pages of EEG. One study per day for one electroencephalographer who reads every day is going to generate 2 million pages of EEG per year, and that's a staggering number. There's not a lot of data on how long it takes us to read and report EEG. This is the data that I could collect. So if you look at a normal 21-minute routine EEG, it takes most people about 8 minutes to read and report it. But if it's abnormal, it's going to take longer, about 20 minutes. And if it's abnormal but has seizures, you're looking at somewhere closer to 40 minutes. If you're reviewing longer stretches of EEG, the average amount of time that it takes somebody to review a 24-hour EEG without seizures and report the results, 38 minutes. But if you're reviewing it and it has seizures, you're looking at almost 45 minutes. So let's make some predictions based on that. If you have 10 patients who are on continuous EEG monitoring, statistically speaking, 2 will have seizures. So you can calculate 44 minutes to read, 30 minutes to report. That means you're going to spend 2.5 hours on those 2 patients. And then the 8 without seizures are going to add another 6 hours and 24 minutes, which means that you can estimate that the amount of time that it will take you to read if you work at current baseline operations will be 8 hours and 52 minutes. I don't know about you, but I am never given 8 hours and 52 minutes to read 10 studies. One of the big challenges is that we have seen tremendous growth in the amount of continuous EEG that's being performed, but we haven't seen tremendous growth in the number of people who are being instructed on how to perform continuous EEG. So if you look at the green line here, this represents the number of people who are completing clinical neurophysiology and epilepsy fellowships, and you can see it's gone from 210 back in 2008 to 292 in 2024, and it's worth noting some of those people will be neuromuscular. So we are not graduating tons and tons of people every year who can read continuous EEG. I would see an even more significant issue is the availability of technologists. So each technologist, if you estimate that they work about 36 hours per week, 48 weeks per year, because you got to give people vacation and sick leave, that means they're going to work 1,728 hours per year. That means that you will need a minimum of 5 technologists to monitor your EEGs continuously, 8,760 hours per year. The current CPT code says that we should have a ratio of 1 to 4 to provide continuous monitoring. That requires 20 technologists. To get just a 1 to 12 ratio requires 10 technologists. And right now, only 30% of academic centers where we have the highest number of technologists have more than 15 EEG technologists on staff. Based on US Labor Department estimates, there is an 11,000 person shortage in the number of neurophysiologic technologists who are currently available to perform studies. And as I mentioned, although we've seen a modest growth in the number of fellows graduating from our programs, we have seen a tremendous growth in the use of continuous EEG monitoring. It used to be in 2004 that only 0.3% of individuals got continuous EEG. Now what we're seeing is a growth to about 0.8%, but that growth goes up and up. Even more recent studies suggest that between 2014 and 2019, the number of patients who are receiving continuous EEG monitoring in the context of cerebrovascular disease has seen a tremendous growth from 713 to 3,310, with more and more hospitals performing EEG services. So the question becomes, how do we deal with this overwhelming amount of data and the overwhelming need to perform these studies? One possibility is, could we use quantitative EEG to make our reading a bit faster? A little bit more than half of us do use quantitative EEG, and when it is used, it's overwhelmingly used for seizure detection. The challenge is about 47% of clinical neurophysiologists feel that they lack the expertise to use it well. 28% do use it, but they're concerned about false positives. And the other elephant in the room is that it's expensive, and many facilities will not pay for quantitative EEG. Having said that, it can be used to reduce reading time. The estimated reading time, if you just look at raw EEG, is 19 minutes. If you combine raw EEG and quantitative EEG, it's 14 minutes. And if you just rely on quantitative EEG alone, it becomes 6 minutes. It can also be used to expand the ability for non-neurophysiologists to interpret EEG. So as we look at our technologist shortage, we're trying to find ways that other people can help us to identify concerning patterns on the EEG. So there have been several studies looking at other people who might be able to fill in some of the gaps in manpower. Some studies have looked at neuro-ICU nurses who have a reasonable sensitivity and specificity, although they do have somewhere between 1 and 3 false positives per hour. Neurology residents and ICU fellows can also be used with a reasonable sensitivity and specificity. And as mentioned before, EEG technologists are still probably the most commonly utilized, but because of our technologist shortage, that is probably not our best long-term solution. And again, quantitative EEG is not a perfect tool. Depending on which study you look at, there can be significant false positives as well as false negatives with it. Some have found that the more broad panels that you look at with more different trends, the more likely it is that you'll have better sensitivity and specificity. So then there are other possibilities. How can we contemplate other ways to potentially expand our ability to read ICU EEG? Well, in Thailand, they recently did a review looking at tele-EEG. There was a randomized controlled trial in which they compared the use of tele-continuous EEG with routine EEG. They proved that as a model, this is feasible, but they didn't show that the routine use of continuous EEG improved outcome or mortality. Having said that, there are a lot of companies now that provide continuous EEG services. So some facilities have relied on using these facilities to provide them with added overnight coverage or weekend coverage. In a couple of facilities that I've talked to, they've now instituted the process of EEG hospitalists. If you're going to be staying up all night reading continuous EEGs, it's hard to do a full clinic the next day. So they have people who read and generate reports overnight and then don't see patients the next day. Some people also have exclusive weeks where all they do is EEG and they don't see patients in any other capacity. The challenge is, how do you pay for this type of service? How do you do this and still maintain an active and thriving epilepsy practice? Another area of deep interest is the use of artificial intelligence. Can we use AI to potentially highlight EEG areas of interest, maybe cluster or highlight concerning patterns so that we can look at it? There are some studies that suggest that this can be almost as good as using expert labeling. We could certainly potentially think about using this to assess responses to treatment. And some people are exploring the use of AI for prognostication in anoxic brain injury, TBI, and other disorders of consciousness. So I hope that I have set the stage for our next two lecturers who are going to talk a little bit more about some other ways that we can potentially be more strategic in the way that we allocate EEG resources, including some other technological solutions, including reduced montage hookups and devices, and more strategic allocations of EEG resource. And with that, I am going to turn it over to Dr. Strzok.